Surgery for tuberculosis, cardiothoracic masterclass. Since 1952 and due to emergence of the modern anti-tuberculous chemotherapy, surgery for TB has been abundant. Until the present day, chemotherapy has been the main treatment method of tuberculosis, including its drug-resistant forms. However, with the emergence of multi-drug resistance and extended drug-resistant TB strains of Mycobacterium tuberculosis, this has resulted in resurgence of almost incurable and even fatal cases. M and XDR TB currently represents a critical challenge for global TB control, owing to the few therapeutic options available. The indications of surgery for tuberculosis is still reserved for complications of the disease. And this can be categorized into emergency, urgent, and elective surgery. In emergency situation like profuse hemoptysis or tension spontaneous pneumothorax, surgery should be based on emergency prompt management. Urgency can be seen with irreversible TB progression despite adequate anti-tuberculous chemotherapy. Patient presented with recurrent hemoptysis that cannot be stopped by other treatment methods. Elective cases are seen in localized forms of cavity TB with continuous Mycobacterium tuberculosis excretion, confirmed by bacteriological examination after 4 to 6 months of supervised anti-tuberculous chemotherapy. MDR and XDR TB characterized by failure of anti-tuberculous chemotherapy or complications and sequelae of the TB process itself. Indications of surgery can be summarized in the form of diagnosis of complicated cases, elimination of contagious persistent cavities despite appropriate chemotherapy, treatment of destroyed lung, resection of tuberculomas, or treatment of TB pleural impipe. Surgery can be a tool for diagnosis of patients having tuberculosis, whether through mediastinoscopy, open or video-assisted thoracoscopic lung biopsies. There is a low performance of CT-guided biopsy and even transbronchial lung biopsy that does not exceed 60% in many cases. The radiological criteria for malignancy can be identified in up to 66% in patients with confirmed tuberculoma. And in patients with suspected malignancy, these cases should be biopsied. Lymphadenopathy in the absence of parenchymal lesions. Elimination of contagious persisting cavities despite appropriate chemotherapy. TB patients with a persistent positive sputum smear may benefit from surgical resection of bacillary pulmonary lesions. This therapeutic option is mainly reserved for multi-drug resistant tuberculosis. Patients with one or more of the following clinical features can be considered as potential candidates for surgery, and those include persistent positive smear test and or culture despite appropriate chemotherapy, relapses, and high risk of relapses based on drug-resistant profile. Destroyed lung per se refers to the radiological appearance of fibrotic cavities combined with caseous lesions, frequently accompanied by sublobar atelectasis or bronchiectasis. And other typical signs include the upward displacement of the lung hilus, the mediastinal shift toward the affected side, and the narrowing of the intercostal spaces. Most patients with this radiological condition usually present with a history of exposure to multiple TB therapy or delayed recovery and or drug resistance. Usually the main culprit presentation is hemoptysis, and for this situation they may present on emergency basis or elective or urgency. The mortality for this procedure in emergency basis is 40%. For that reason, embolization of the bronchial arteries is usually preferred, with an immediate success between 75 and 94%. However, the main problem with embolization is the high recurrence, considerable recurrence rate at 18 to 42%. The approach for this patient should be extrapleural because of the severe adhesion, and in these cases, the bronchial stump should be covered with viable muscle. Resection of tuberculomas is indicated to reduce their infectiousness. However, as they may present with a solitary nodule ranging from 1 to 10 centimeter and positive PET scan, they may confuse with malignancy, and for that reason, resection here is to confirm or exclude malignancy. The natural history of pulmonary tuberculoma can be divided into progressive, stationary, and regressive. Stationary status account for 30 to 50% of all patients with tuberculoma. The management should be in the philosophy of lung-sparing procedure with typical or atypical mono and bisegmental resection. However, in many cases, lobectomy may be indicated when it is located near the hilum. If anti-tuberculous treatment is not performed preoperatively because of differential diagnosis for malignancy or because of the nodule was not diagnosed, it is usually administered postoperatively in these cases. Treatment of tuberculous pleural disease may present like TB pleural effusion, TB pleural empyema, and bronchopleural fistula. In patients with the pleural effusion, without any radiological signs of TB, diagnosis of TB pleuritis can be performed histologically only after removal of the thickened pleura. In patients with tuberculous empyema, if pleural empyema occurs with radiological signs of TB, conservative treatment with prolonged chest tube aspiration or drainage is strongly recommended. Surgical therapy, open approach, is suggested only for cases with major residual pleural thickening. In patients with bronchopleural fistula, tube thoracostomy is the initial treatment option. Open thoracostomy window is usually recommended for severe ill patients with a high operative risk. Two-stage management with open thoracostomy and subsequent muscle plombage of the cleaned residual space is also suggested as a reasonable alternative in patients with poor general conditions and extensive calcification, precluding decortications. Recommendations for surgery of TB. Dense adhesions can be a relative contraindication to surgery, particularly for video-assisted thoracoscopic approach. If all thoracotomies is going to be done, muscle sparing technique is usually utilized to keep the muscle ready for any future muscle flaps. Preoperative bronchoscopy is mandatory, including biopsies from the anticipated suture lines and from sites with suspected active disease. Endoscopic confirmation of tuberculous bronchitis is a contraindication for surgery because endobronchial granulation, tissue erosion, and ulceration of the mucosa may predispose to the development of bronchopleural fistula. Summary of evidence. If bronchoscopic biopsies fail to confirm diagnosis, video-assisted thoracoscopy or mediastinoscopy are valid alternatives. Diagnostic thoracotomy is rarely necessary but may be considered in selected cases. Surgical exploration with ex-tempore histological examination may be helpful and should not be delayed if reliable radiological criteria are unavailable to distinguish between malignant and tuberculous lesions. Bronchoscopic biopsy for bronchial mucosa aimed to exclude TB is of utmost importance before proceeding to pneumonectomy for a destroyed lung. In multi-drug resistant TB patients, surgical resection of pulmonary bacillary lesions may be useful to improve treatment outcome if chemotherapy failed. But before complete destruction of lung parenchyma and associated decline in pulmonary function, maximal parenchymal sparing surgery should be preferred in multi-drug resistant TB patients due to their high relapse risk. Tuberculoma should be surgically treated to reduce infectiousness. Appropriate imaging technique should be adopted to discriminate lung cancer and tuberculoma. When pleural effusion occurs without any radiological signs, open surgery is suggested only for cases with major residual pleural thickening when TB pleuritis is immediately detected. Bronchopleural fistula should be managed with a chest tube thoracostomy. Post-operative chemotherapy is mandatory. After the removal of the main lung lesion, as some nodules and tiny cavities may persist and can favor relapses. The following duration of antituberculous therapy is recommended for culture-positive patients at the time of surgery. With drug-susceptible TB, 4 to 6 months of therapy after culture conversion. With multi-drug resistant TB, at least 18 months of therapy after culture conversion, and with extended drug-resistant TB, at least 24 months of therapy.